an attempt to make a small clip about cancer and start off with several cancers I treated in my lifespan. Uh, Now I'm retired and I don't treat cancers at all or anything, but I occasionally, many times, I get consults about various types of cancers and other problems. So-called OTC, over the counter consultations are just an opinion, and I help people in every way I can. These medical consultation are not necessarily confined to cancer problem, but almost all medical problems. So that's how I'm going to start. Now coming back, I have to introduce myself. I'm a fellow born in India nearly 80 years ago, 80 years ago, and came to this country at the age of 24 to make some good living and training and fame and money. And my intention was initially to stay here for 5 years, make some money, and get a big degree in front of my name, and go back to India, get married, and start my medical practice and make a lot of money. It didn't happen, so things continued. So again, I'm going in a fast forward mode. That is in fast forward mode. I had training and experience of cancer patients, but not with solid cancers like breast, colon, or lung. My training I started as a blood specialist, uh, and I initially learned treating blood-related cancers, which are leukemia, lymphoma, and Hodgkin's disease, things like that. The names are very familiar to a lot of people. I am extremely fond of children and babies, and I can't tolerate even a child crying. So I deliberately avoided uh, treating little young babies with any type of cancer in the initial practice of my life. And I said I don't have any training on that field. Anyway, that's how I started. So I started my private practice in 1977 and called myself a hematologist and hematological oncology, like that. Then the cancer business is totally, even those days, it's a referral practice. That means somebody has to refer because I'm a specialist in the field, but only the referring base is mostly primary care physician and the surgeon who operates and diagnoses the cancer. Then only referral starts. No patient will come. Those days, no patients used to no used to come directly looking at yellow pages or from advertisement. Such things never existed. So that was 1976. Compared to 1976, 86, 96, 2006, nearly 28 years. I retired in 2010, and the whole field of cancer care has changed. Whole system of healthcare itself was changed. So those days, doctor was a god. Doctor was the boss. Doctor controlled everything. Today, outside it looks like doctor is a god and boss, etc. But the doctor has no clout at all in their own doctor's circle because of the change in the healthcare delivery system. And today's healthcare system, money making is the important thing, most important single factor in this today's healthcare delivery system. And all other delivery systems, not only healthcare, any such of lawyers or consultative delivery system, quick money, cash out and get out. Those days, patients used to sit in the hospital for 6 months, up to 6 months, under my service. and everybody was happy. That model I will explain later on doesn't pertain to this. But this time, today's day and age, most money is made when you keep the patient least time, and most money is made when you get the maximum number of procedures, etc., in the record time. And again, most money is made from referring that particular patient to so many ancillary services like social care, team care, that care, this care, everything. And the insurance reimbursement pattern is different today compared to so many years ago. But what is all the relevance about all this, telling all those things? Uh, the relevance of telling these things is it is important for the patient to know everything he or she understands, and people tell you should always have a skeptical mind and analyze, don't get to conclusions, and don't despair. Don't be in despair. If somebody said, yeah, you have a cancer, even if his diagnosis of cancer is made, in this particular instance, breast cancer. So let me focus on breast cancer. Um, Before focusing on breast cancer, my practice did not build up at all. Just calling that I'm a referring physician. I mean, I'm a specialist in just hematology, uh, hematology. I had a full training in it. That's why I was saying I started as a hematologist. If you step back another 20, 15 years from my time I started, there was no specialty of any kind at all. Just a GP or general practitioner. Even this name family physician did not exist. And then surgeon, there is only one type of surgeon, general surgeon. Then OBGYN specialty. That's it. Maybe a psychiatrist. So now there are every specialties, subspecialties have mushroomed all over, as if cancer itself. There are specialists for everything. Uh, and cancer incidence also has increased, but diagnostic technology and techniques are also increasing because that's where the money is. With that in mind, when I was starting practice, my referring physicians wanted to dump some of this terminally ill patients with other malignancies like colon, cancer, prostate cancer, and lung cancer. They used to ask me, Doc, do you also treat solid malignancies? I said, I have some experience because the same medicines are used in hematological malignancies, so I can take them. And later on, slowly, I was getting so many patients who had no insurance or something. They used to send me as if they are doing me a favor. Then I had to open the this is called PDFR, Physician's Desk Reference. There is a huge fat book which tells all the names of the medicines, cancer medicines, and indications, contraindications, side effects, what to do, what to monitor. I read the PDF is called. It's a big fat book. Drug companies used to give it to us free. So I used to refer to that book and a couple of journals like New England Journal of Internal Medicine, which is a gold standard for doctors that time. I don't know what is the journal they use now. So every time a new solid malignancy patient comes, they tell me there is a consultation in the hospital. I have to go home and read that book. And most of them can wait because as soon as the biopsy is done, they will call a consult. A biopsy done and the pathology report comes back. Then only they used to call a medical oncologist. Some people will call even they suspect a lump and they, hey, you go and look at it. So referral pattern in this our practice at that time was entirely different. But then since I didn't have much experience at all in solid cancers, I had to go to the book, which is not what a book. It's not a cancer book, just a PDA. I think physician's desk reference, big fat. All the medicines are listed there, and all the medicines indication. They said published by a drug company, and they used to give it to all the doctors free of cost. So I saw the book and brush up my knowledge about how to treat. Then when I go to the patient's bedside, I say I'm an oncologist. I'm a specialist in cancer. I didn't say oncologist. To start with, I didn't even know the meaning of oncology when I came to this country in 1967. What it meant. There was no oncology specialized subspecialty called medical oncology when I came in 1967. There is only later only specialty was internal medicine, but later on hematology came. There was not even medical oncology. Anyway, that was the beginning point. So with that in mind, I knew everything about breast cancer pathology, pathogenesis, anatomy of the female breast because I spent 3 years in anatomy, studying anatomy in my med school in India. But certain than the lymphatic drainage system has to be of a breast or any tissue. And talking about cancers, three fundamentals one need to know. Number one, where did the cancer come from? And what is the type of the tissue which become malignant? Number two. Number three is location of that starting point. Number four is checking whether it is confined there or it has gone to some other area, like lymph nodes or something, or blood system and all over. So because all these things are important for a doctor to understand even before talking to the patient, to tell him or her about the details about the patient's condition when that patient is referred to a specialist like me. And generally, people refer to a medical oncologist, that is a cancer doctor who is specializing in uh, chemotherapy kind of a field when the tumor or cancer is presumed to be all over the body, which cannot be removed by removed or controlled by other means like surgery alone or radiation or combination of surgery or radiation and radiation. So such patients used to come to me, and my patients, my title was when I was starting my practice, some of the patients used to call me undertaker. So that was the thing. In a doctor, primary doctor refers a patient to medical oncologist like me. It was nothing but a fear from the patient that he or she is in a terminal stage. It is absolutely not true as we speak today. I will emphasize once again, it is absolutely not true as we speak today about cancer care. And the advances of cancer of all disciplines have advanced so much in last 25 years. Uh, there is no need anybody to be afraid of cancers as it used to be before, but still that fear is always there. That is the reason why I am emphasizing that the medical oncologist is no longer a undertaker. Medical oncologist with good training, with the help of the modern medications and supportive care of all the disciplines, can uh, treat advanced cancers or stage 4 cancers in a most effective way to improve the quality of the life, duration of the patient's remainder of stay because of cancer, and in coming back to breast cancer, even in advanced cases of breast cancer, there are so many excellent medications available which can even cure them in a very high percentage of patients. If one in 100 breast cancer patient with the stage 4 or advanced stage gets cured with some kind of a medication the doctor gives. And the probability of response uh, one in 100 patients a response, one can presume that it's not doctor's work, some kind of a miracle. But today, in the same stage 4 breast cancer, one understanding different types of that patient has that breast cancer, and there are so many advanced tests which will tell you what type of a cancer. In breast cancer itself, there are so many varieties and sub varieties, and all those things a lay person doesn't have to know in the day one. He or she is not even interested in knowing it. What can be done for that person? That's all. So again, when the patient comes to even in a tertiary long, so-called advanced stages to a medical oncologist, the so-called undertaker like me, um, my job is not to jump in and say nothing can be done, go home. No, a lot of doctors do that in a medical oncology situation today, particularly when they find out that patient is shopping around or that patient is a pain in the butt, and then even after getting an opinion, he or she will not stay with you and go to other doctor. And thirdly, uh, they find out that that patient does not have insurance. So if there is no insurance all the time for and the insurance and they cannot pay from pocket is impossible. Today's economy, anybody, even a millionaire, can become a pauper in one night, one treatment. One having one advanced cancer. So with that type of situation, I should be extremely careful how a person. But my approach always been any terminal patient or whatever level they used to come, even when there was no uh, effective treatment for that, and I knew the statistically speaking the median survival of such patients. I started with a systematic way of doing a history, physical, complete thorough physical examination, then reviewing all the lab tests. I used to run my own lab tests. We used to have a lab, things like that. But then I go to the hospital and sit with the pathologist and discuss the type of the cancer, look under the microscope myself, all the things, and discuss the findings of the pathologist. Used to sip a cup of tea or something and chat and take a donut, and then come back, then go to the radiology room, and whatever x-rays are there, check with it, like a mammogram with the radiologist, and again have a coffee or chat. My practice was not big because I was a foreigner. Nobody gave me the so-called the cream of the crop. They only throw in crumbs, and that's important for you to understand, the people to understand the complexity of the referral system and money making system and how it has evolved. That's why I'm saying I'm not sure I have plenty of money and I have enough money for food to eat. No problem. I'm not even going to discuss that. So with that in mind, no, so why I am saying that is then only one can get, even in advanced stages, you go back and do all those things, then only you will get the comprehensive picture, mental picture of the what type of a cancer I am dealing with, and there's I can't explain that. That will give me a gut feeling what to expect with that cancer. That is the sharing the thoughts of other specialties, that namely radiology and pathology, and other technology like blood testing for a very very minute quantity of cancer and what type it is, all evolved since I retired. And today's modern technological thing coming focused on breast cancer itself. Oh my God, one should not despair at all. There is a lot of advances, and multi-prong approach, multi-tumor, multi-discipline approach. Um, Generally speaking, a high percentage of patients with breast. I'm only confined to female breast cancer now. because male breast cancer are rare. I will address this later on. Mm. So, so that is important for one to know. The other thing for anybody with cancer, and particularly with female with breast cancer, also ought to know two other things. One is, do not do any rash things just because your primary care doctor or surgeon says your lump turned out to be cancer. Some people find a lump and they're despair. They are in despair, in extreme distress. So a lump is found, and the primary care fellow tells, go and have a mammogram or something, or a ultrasound or something. You have a lump. I found a lump. As soon as he or that producer, that used to produce, or even today it produces some unstable patient, mentally unstable or even stable patients. We are illiterate. They are so fearful. They get that so much of fear, they commit suicide. It is a common thing in India. Indian, particularly India, people find out they have cancer or something, they simply stay at home and commit suicide. Sometimes commit suicide. And in India, women, the most common cause of suicide is pregnancy out of marriage. Young girls being abused by different people, and that culture is changing, thank God. Similarly, the fear of cancer, cancer phobia. Some people, they say, my grandmother had cancer, she died, so chop both my breasts off, like that, because it may come because somebody said it is hereditary, something like that. So many things are there. One patient says, I have a lump there. The doctor says it's probably cancer, so why don't you take both my breasts off? And even biopsy is not done, mammogram not done. That type of fears are there even today. So it is again and again and again. I will tell 100 times until my mouth dries out. Don't fear, don't fear, don't fear. The underdog is here. Don't worry, the underdog is here. The God is here. Technology is here. Support system is here. Diagnostic techniques are here. Even in advanced cancer, you can. We used to also pursue, and in advanced cancers, I said both breast and other cancers. I have given treatment for 2 to 3 years more than what is really necessary, because of the factor that it may come back. And these 2 to 3 years of sustained maintenance treatment, systemic chemotherapy treatment, will prevent those cancer cells, hiding cancer cells will show up and all. Again, those also becoming less and less because of the advanced technology. With the blood test, one can reasonably presume, with a very, very up to the molecular level, that these cancer cells are completely gone, and that eliminated the use of prolonged chemotherapy or immunotherapy, etc. So those days, advanced cancer, only thing could a medical oncologist, the so-called undertaker, could do is chemotherapy, like me, and there are very few medications on hand. They all had high degree of toxicity, and response rate was only less than 20-15% in breast cancer. Then somebody found out combining two medicines will reduce the toxicity and increases the response. So that's called combination chemotherapy. Sometimes they found out that chemotherapy with radiation therapy to the regional radiation therapy prolongs the survival, and that is slowly that technology improved, and concurrently diagnostic techniques of detecting breast lump or breast cancers improved, which included a mammogram. And there are so many advances in the radiation technology, so that minimal amount of radiation was delivered to the breast tissue, because some other jokers told that too much of radiation produces cancer. Again, some of the patients do not do breast cancer, and cancer, particularly breast cancer, And in Europe, for example, they don't do mammograms at all. And here, if you don't do a mammogram annually, if a doctor does not order mammogram annually, he is liable for medical malpractice. These are all, I don't want to discuss too much at this point in time, because everybody has to. I'm not up to date. What is the recommendation for a mammogram? Is it annual mammogram is necessary or not? They are not in diagnosing, detecting breast cancer in an early stage. But at least for God's sake, tell your husband or boyfriend to check your breast once a month. Train him or her. Secondly, you yourself do breast self-examination, but don't be obsessed and worry about there is small little lump there, here and there. It could be cancer. Don't go with the myth of with the fear of cancer phobia. If a cancer phobia is there, don't even touch your breast. That's my advice. That is my opinion, not advice. I am not going to advise anything to anybody. Absolutely nothing. That's my philosophy and sentiments only, I can tell. But I can give encouragements uh, to the extent that the technology is so advanced, you can everything can be handled. There is a thing called art of medicine and science of medicine. Americans, particularly, think American Hippocratic doctors, particularly, think most of them think it medical medicine, not only cancer medicine, is a science. It is a science, maybe, but there is more art to it. The art comes in compassion, experience, hand holding, and how you the caregiver, that is either a medical oncologist or a primary, deals with that particular patient with that particular condition at the particular moment. That is an art. And and also the doctor's experience is a lot to do with that. Elderly doctors who has seen all these patients suffering and dying, their approach to a new patient of any kind is entirely different from these modern day youngsters. They act like robots. That is my observation. They talk like experts, but act like robots. So this is there should be a optimum mix of the art and science and teamwork and togetherness. Without that, nothing can be accomplished in anything, including a young girl with a breast cancer. The other thing is about fear about the distortion of the image. You know, that is very, very important for girls, women, their breast appearance. So some where person very afraid, say chop off the two breasts right away. Other one say they're more interested in the best breast reconstruction. Those days it was not considered. When I was training and I was treating my breast cancer patients, it was not even covered by insurance. For that, they had to spend more money than the entire cancer treatment from a plastic surgeon or somebody. They also it's all cash and carry, and they made a fortune. But nowadays, with the change in the technology, this one healthcare delivery, some of them are also ironed out, and insurance company is also making money out of that. Pay the breast reconstruction as an indicated procedure, not medically indicated. That's what the word used nowadays. So those days, it is not. It's a cosmetic problem. Surgery is not indicated medically, so they had to spend a fortune. Uh, then not only nowadays it has gone to the other extreme. So they not only reconstruct the breast, then they put a little nipple, they put a little tattoo and match with that. And they reduce the or augment the size of the other breast so that everything is balanced. Why I am saying this in this type of detail is all these people have a vested interest in all those technological machines also, including Humana and all those other people. They also have, they show the Humana man calls me every other day and come and get a colon checked. They even sent a thing called Cologard, that is screening for colon cancer, and I threw it in the garbage. I didn't use it. That's my story. But let's be focused with the breast cancer. So this this the modern age, and I told the biographer that let me read up on this and then start my story about how to treat breast cancers. But I said there is no. If I start, what am I doing? Am I coming up with a perfect finished product right away? Like Leonardo da Vinci did, drawing the Last Supper of Jesus, Jesus Christ's Last Supper, and that is the perfect one he produced. But people don't have such patience to, uh, in this modern age. Hurry, 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 hurry. Everything is a hurry. So with that in mind, one should be one should to start somewhere. Then you can always tweak and improve this product and concept, depend on the feedback. And the whole bottom line is this kind of a product is going to help somebody. In a bigger the number is better, but even if it helps one person, it's okay. But it should not hurt anybody by this type of a presentation. Uh, so that is important. So now I already finished 31 minutes of introduction to breast cancer, breast cancer, female in females, and now uh, we can do something more. Uh, Another day, I want my biographer to look at this clip and see, and I need a feedback from her. Then we will do something else. So this is only 32 minutes of a kind of a introductory thing about treatment of female breast cancers in 2024. And I will continue in the next chapter. How I will continue in the next chapter how a breast cancer was diagnosed in my own spouse, who happens to be a doctor, and I will continue with that episode in the next clip. Thank you, biographer. Hare Krishna.